Thank you very much, Caroline. Declan Cahill from Guy's Hospital in London. As a matter of serendipity, I want to just show you this cartoon, which I was sent 2 weekends ago whilst I was actually preparing the talk from a patient of mine. My friend, the year is 2011. I have a machine that can look through your skin and see your bones. I have a machine that can keep you alive even if your brain and heart don't work. I even have a machine that can look at a drop of your spit and tell you who your parents are. But right now, I need to roughly gauge the approximate size of your prostate, so I'm just going to stick my finger in your butthole and wiggle it around a bit. So I think that's very relevant to prostate cancer diagnostics, and it's going to be particularly relevant for Claire Allen, who's following me and talking about the technology. But we can certainly put our house in order by getting our bit right, which is the tissue diagnosis. So prostate cancer diagnostics has been described already as something that we've got to get right. We want to diagnose the real stuff that counts, and we don't want to hurt our patients while we do it. The challenges of early detection are the lack of specificity of PSA, the fact that there's no PSA cutoff, there's no symptoms of early disease, and imaging and molecular characterization aren't there yet, and we hear this over and over again. However, we've got a lot. I mean, we've got an awful lot of information, and clinically switched on, experienced urologists can get it right the vast majority of the time. The most important thing we can do, and we can do very easily, is avoid the number of unnecessary biopsies we do. So the obese 75-year-old diabetic with no teeth, a PSA of 9 and large BPH does not need a biopsy. The challenges in biopsies, these are the chapter headings in the book. What's the optimal number of cores, sextant versus extended? Where do we biopsy? Which sites? Lateral, peripheral zone? Do we do systematic or targeted biopsies? Do we repeat biopsy if the PSA is raised, the suspicion is still there, and if we do that, how do we do it? What's the optimal pathological processing? What is insignificant disease? What about overdiagnosis and overtreatment? How can we identify the gold standard? There's a verification bias in all these studies because we don't know how many people within each of the studies actually has cancer, because by definition they're a sample. And then the other question that I'm going to gauge and answer today is whether or not transperineal biopsy offers any advantages over transrectal biopsies, and how should you choose that? Transrectal biopsy has been unchanged in 25 years. It's done under local anesthetic. It's often done by junior staff with minimal supervision. It's principally now a laterally directed 12-core peripheral zone biopsy. Cancer detection rate of about 44%. Misdiagnosis, we've heard already, about 30%. And saturation transrectal biopsy doesn't underdress the sampling error in that the anterior part of the prostate still hasn't been looked at. So repeating a transrectal biopsy is merely resampling the same area you didn't find cancer last time. The transperineal biopsy is done under general anesthetic. It's painless. There's no fecal contamination. Saturation biopsy is straightforward. It's merely an increased number of cores. Adequate sampling of the whole gland is easy, not difficult, not a challenge. There are people in this room who can sample the anterior prostate transrectally, but most can't. With transperineal biopsy, it is easy. It's labor-intensive, however. It's expensive. There are concerns about overdiagnosis. But then in 2013, should we be concerned about overdiagnosis? Can't we just manage it? Retention with higher core number, and it lends itself more easily to MRI guidance. When you have a transrectal biopsy that shows no cancer, no means no. Now, a transrectal biopsy is in the longitudinal on the left, and on the right, the transverse image has got a very good and easy way of sampling the peripheral zone that we can feel rectally. But it is difficult to sample the anterior zone, particularly in large prostates. And as I said already, you can see on this slide how it is very easy to sample all areas of the prostate when you're coming from the area of skin between the scrotum and the anus and the perineum. And this is depicted again looking at the anterior core, sampling the mid-gland and the posterior core. So we do the transperineal biopsies under general anesthetic. We do use antibiotic cover, particularly if they've had a transrectal biopsy previously. There's no bowel prep. Alpha blockers to those who are very symptomatic but not routinely, no catheter, 6 cases per list is practical, although tongue-in-cheek, we all work with different people. We prepare our biopsies. Each cassette costs a penny each, but you can place the cores from lateral to medial, so you know where they came from rather than mixing them up in a bottle. You can ink them so you know which is apical and which is basal, and you get a lot more information from your biopsy. So each bang of the gun is delivering you a lot more information with which you can manage that patient. This is my colleague Rick Popert. I'm not going to give you a long video, it's just a short video just showing an anterior core, the peripheral zone laterally. Betadine prepared skin, it's clean. There's a good, easy sample of the anterior prostate. I'm now going to describe to you some of the data. The British data, the PROTECT study, which I think everyone can be very proud of, and a sample of that study looked at a section of men and their prostate biopsy morbidity. And this is really important. They gave questionnaires to the men at the time of biopsy at 7 days and 35 days following the biopsy. 44% complained of pain, 7% that was a major problem, 18% had fever, 6% of whom was a major problem. Hemoejaculate, 93%, 30% almost said it was a major problem. At 7 days, 20% of men reported that a repeat biopsy would be a major or moderate problem. It does strike me that it is exceedingly unfair to rebiopsy a man who's had one transrectal biopsy with another. The hospital admission rate was 1.3%, and 10% had primary care consultation for problems. Prostate cancer was found in 35%. From America, from a sample of the SEER Medicare database, the admission rate to hospital following a transrectal biopsy is 7%, half of which are due to sepsis. And from the European screening study, from a section from Rotterdam, the risk of fever was 4% and hospital admission almost 1%. The risk factors were diabetes and large prostates. And the frequency of admission increased year on year, which is thought to be due to increased antibiotic resistance. Although, again, it is surprising that we have all these fevers and we all experience these cases of sepsis, and men are admitted to ITU, but it's amazing in the European screening studies there were no deaths from prostate biopsy. Antibiotic resistance, I'm not going to elaborate too much in this talk, but extended spectrum beta-lactamase, E. coli, other fluoroquinolone-resistant bacteria are a real problem. And within our careers, I'm 45, before I retire, I'm going to have some very challenging times of men with infections for which I've got no antibiotics. And our risk of death in our practice from infection is going to become very much higher. And we have to prepare ourselves for the inevitable and find ways to avoid that. There are 3 randomized controlled trials looking at transperineal biopsy versus transrectal biopsy. However, they don't help us with this argument because they're not looking at what we're looking at today. They weren't using a template. They're using a low number of cores, and that explains why they didn't find any difference. There are 4 good large case control studies, and they found no difference either. But again, they weren't using a template. So I'm going to tell you a little story about Daisy the cow. And so where you've got no good evidence, you have to come up with an opinion. So let's start off this now. From what I've told you so far, can I have a show of hands? Who in this room would have a transrectal biopsy over a transperineal biopsy? Okay, looks like we don't need Daisy the cow. But Daisy the cow, Daisy the cow, but you admit it, you offer it to your patients. Daisy the cow was the prize in 1906 at a fat, stock and poultry exhibition, and in order to win her, you had to guess what her weight was, and 800 people guessed what her weight was. There were a very small number of experts, but most people were just local town folk, and not one person guessed the correct weight of Daisy, and she was in fact 1,198 pounds, but the average of all the answers was 1,197 pounds, and this is called the power of the crowd. And so I think the power of the crowd today has said that you shouldn't be offering your patients transrectal biopsy since none of you would take one yourself. However, I will carry on the talk because I do have I do have some more to show you. Now I'm just going to highlight some studies which I think there are things that we can learn. You know, if you do transperineal biopsies, you get better correlation with radical prostatectomy specimens. You get better characterization of apical and anterior disease. You get virtually no sepsis, 1 out of 747 cases in the Moran study. Sepsis wasn't described in 371 in the Demura study. And if you had a previous biopsy transrectally and you repeat it transperineally, you will find cancer. Now, this doesn't necessarily mean you're overdiagnosing cancer, because these patients aren't the same as the screen population. These are patients whom you suspect to have cancer, but you've missed, and that's why they're having a further biopsy. So these can be significant cancers. If you look at these, we learn that, again, there's no sepsis. There is a risk of overdiagnosis, but I've said in 2013 we can manage overdiagnosis with surveillance. Big glands at a higher risk with high numbers of biopsies of retention. And probably the best study looking at adverse effects comes from the Sydney group, Phil Stricker's group, which was published recently in the BJI. And they identified a great deal of bother with hematuria, a small risk of retention and fever, but septicemia was very low at 1 in 0.2%. The Guildford group, Steve Langley's here today, have published on looking at patients with active surveillance. And they've found that if you transperineally biopsy a patient on active surveillance, 30% of the time, they'll actually have more disease. And so 7% of men, they'll actually have primary pattern 4. And we found the very same thing at Guy's, that if you biopsy 100 men with Gleason 3+3 disease transperineally, a third of them will in fact have Gleason 3+4 or more, and it's amazing how similar the figures are. 8% of primary pattern 4+3, 4+4 or 4+5. And this holds true also for a group of Gleason 3+4 men who went on to who wanted active surveillance, and they were found to have 30% variation on their histology as well. Our case series looking at all our transperineal biopsies in primary and secondary has also shown it to be safe, a significant diagnostic rate, and a very high rate of anterior-only disease. The concern about transperineal biopsy amongst radical prostatectomists is that it would make a radical prostatectomy harder. Now, this is a single surgeon data, but we've matched 88 patients who had a radical prostatectomy after a transperineal biopsy versus a group of patients who had a transperineal biopsy, a radical prostatectomy after a transrectal biopsy. And in fact, the outcome was unchanged. Likewise, there's a big concern about erectile dysfunction and sparing the perineum as we do. And indeed, anecdotally, one does notice a reduction in erectile function temporarily, but erectile function does return to baseline by 6 months. That's that group. However, when we look at our group of men who have a transperineal biopsy done for a second time as part of an active surveillance program, there is a higher risk of erectile function that doesn't go away. But if the active surveillance program can offer a 90% potency rate to a 65-year-old man, as opposed to far lesser potency rates with radical prostatectomy, that's not a bad thing. The big problem of transperineal biopsy in the NHS today is that it's coded the same as a transrectal biopsy, and so we simply can't afford it. So how to decide? The transperineal biopsy wins on diagnosis, infection, for active surveillance programs, and acceptability. However, it's very difficult to provide a service for this in this day and age, and it's expensive. At Guy's, you don't have a transrectal biopsy a second time. If there's further diagnostics uncertainty, you'll have a transperineal biopsy. Patients who have recurrent urinary tract infections will have a primary, as will patients who have recently had antibiotics because they've been shown to have higher risks of ESBL, E. coli, recent foreign travel for the same reason, infection risks such as diabetics, large prostates, and patients who are obstructed. And there's another clause if you like the patient. This is another example about the power of the crowd that I'm just too, I can't resist telling you again. It's the same as Daisy, but Google were explaining how their data is so good. And this is a jar of beans. And there's a couple of hundred people in this room. Just 160 people were asked how many beans were in this jar. And there were some very unexpert individuals that chose 400 or 50,000, when the correct answer was 4,510. But the average of all those crazy answers came to 4,115, just 5 out. So the power of the crowd is good, and the power of the crowd this morning, I think, has said that transperineal biopsy is a better way to look at the prostate.